So this is a great follow-up to that wonderful talk because so much of that was based around how do we study the changes that we're making? How are we doing it in such a way that we can go back, look at it, publish it, and tell other people? Well, this is very much a talk about how we actually did a lot of the interventions that we've been talked about, very much a case study type idea. And this is how do we actually do, the boots on the ground, operational excellence in emergency medicine. So it's a wonderful second follow-up, and I'm going to use this. So a little bit of background about us. We're University of Colorado Hospital, coming from UC Health. It's a very large system with multiple different types of practice environments. Academic centers, community hospitals, small freestanding emergency departments. We work with critical access hospitals. But in a state the size of Colorado, we are the only academic medical hospital. We're big, we've got lots of annual admissions, we see lots of outpatient encounters. In the whole system, there's a lot going on. So regardless of where you're coming from, if you're working for a place that does a lot of community hospital-based medicine or rural-based medicine or large tertiary care centers, if you're like from Arkansas, where I went to medical school, was over here. Yes, like that is a similar setup where it is the single center in a large state and you're covering a lot of different places versus George Washington, where I went to residency. It is a single hospital right now with a bunch of competitors. There are opportunities for you, regardless of your background and where you're coming from, to look at how we have done things, how we applied a lot of these changes that have been discussed in the research, and move forward. So this is the catch, is that we are all working in these academic centers. And from an operations standpoint, I get to really focus on the patient care circle on this diagram. But at an academic center, we are not just responsible for patient care. Whoop, shift that a little too hard. We are also responsible for education. We are responsible for research. There are a lot of different competing missions that individual faculty will be tied to. So how do you take a group of disparate individuals with different interests and get them to focus on operational excellence? So this is us. This is what we do right now. We believe we have found a way to make this work. We have excellent research. We've got great education. We have 69 residents. We're working at 2 sites. Lots of fellowships. We feel like we have been able to pull this off, but it wasn't easy. It was a long journey. So we're going to walk you through this journey so that you can see yourself, project yourself in what we are doing and what we have done. Everybody knows that we need to provide better care, cheaper, faster. Like everything needs to be better about healthcare in America. But no one really has that great research, the great idea of how to do it. But we do know for sure that we cannot stay where we are right now. That if we keep doing what we're doing, we won't get the progress that every single one of us knows that we need. And this is where we really want to focus on the culture that is developed in your emergency department. So much of operations, of how we do things, is based off of the culture of that emergency department. There's a saying that I have said multiple times, I'm sure a lot of you have heard, that culture eats strategy for breakfast. You can come up with the best idea of how you're going to change the way care is delivered, but if you don't get buy-in from your doctors, if they just stick to the culture that they're doing, it doesn't matter how great your idea is, because the change won't happen. And so we need to figure out how we can change the DNA of our departments, how we can change the focus, and this will involve challenging everything. If you are emotionally invested in your idea, if someone is emotionally invested or personally invested in some concept or some part of how care is delivered in the hospital, in the emergency department, if there are those sacred cows or someone's ego is attached to it, you will have a barrier that will be very hard to overcome. So you need to open up and be willing to challenge these ideas. Now this is a series of steps that was raised by Cotter, who does a lot of work in operations. And you'll see that there are currently 8 steps showing up right here. And this is the model that we were operating with when we enacted our very large change, which Dr. Wiler is going to walk us all through. But you see there's 3 large components. Over on the left, there's creating, I have to make sure I was using my right-handedness there. On the left side of the screen, we got the creating the climate for change, making sure everybody is prepared to accept and invest in that change. Following up is by it says engaging and enabling the whole organization, getting everybody involved, getting your educators involved, getting your researchers involved, and then once you have made that change, you get it working, and you keep it going, that you don't fall back, that you don't slide into the culture that you're trying to change from in order to see that success. So this is a case study of how we did this at the University of Colorado Hospital Emergency Department. And Dr. Wiler is going to walk us through her personal experience, and then I'm going to circle back around, and we're going to recap how we set that up, how we created the setting for change, how we implemented, how we got everybody on board. Oh, yeah. Sorry about that. Move this up there.
I think we're good.
Okay.
Can you hear me? Thanks again for the opportunity to talk to you today. As Dr. Clark said, we're going to talk you through our case study, our journey of an operational change that led to scholarship, and a couple of other things that I'll share with you. I will move through then what we did, because we didn't have fancy Cineo, I tried it. It's really hard to use. It's really expensive. But I tried partnering with many people in business school, including at the time when I was at WashU with a very wonderful woman I still close with, who's a tenured professor, who's a co-author of the book Theory of Constraints. Didn't make it any easier. So what did we do? We just put it down on a piece of paper and ran simulations through our new redesign. And it was, first of all, we did just our leadership team to test using one of our busiest days with our actual achievement plans on a piece of paper and running like a board game. We learned a lot about our process and the opportunities. And then you know what we did? We did it 3 more times with frontline staff. Why? We wanted their great ideas and we wanted their engagement. We wanted to show them that we were in the cycle of rapid cycle testing and then we wanted feedback, but we also wanted their engagement. We did the same thing with running simulations then, ultimately, because we had a brand new space to go into, and then we implemented. So what did we do? We implemented a pivot team. At the time, a decade ago, it was very novel, considered very risky, to put your most expensive resource at the front of everyone's increment. And why did we do it? Because at the time, there was one paper that showed door to provider time, not door to APP, or door to nurse, or door to resident, improve patient satisfaction. We said we were going to focus on the patient. So that was our description of the why we put a doctor in the front end in intake, or a name that we made up, which is now been called PIP. So ultimately, what did that do? That put the senior most decision maker at the beginning of the process of the patient's care journey, and ultimately completely changed our quality outcomes and our length of stay. So we implemented a pivot team. Turns out that we did not pick a nurse to be able to triage in the front, because that's a scarcity of resources that they're triaging to. And if you're the attending physician who's in the front, there is no scarcity of resources. You are that resource they're waiting for. We created standards of work. This was really important. Ultimately became a training tool for us and an onboarding tool. We created scripting, just like other service industries do. They're very specific about using it as a training tool and making sure that we did not have variability in care. We developed tools so that we were consistent in how we deliver care. We implemented scribes. We implemented a point of care testing program, which is ultimately really important for throughput. We 5S'd all of our supplies so that there was no more hunting and gathering. At our facility, our supply room was so far away they call Canada, because you gotta go to nowhere to get it. We 5S'd our stock room, again with those shopkeepers, which was critically important. And this is actually where we failed. We knew it was going to be important, but we moved to our new department and kind of had a plan for supplies. It was the first RIE we did. Within 2 weeks of moving to our new facility, we focused on supplies. We underestimated how important it was. We put a retail pharmacy right at discharge, which is critically important. And oh, guess what? We had $75 off every prescription, and the patients in the middle of the night fill it. This is a huge money maker for us. And we developed care pathways.
In the beginning, literally, I had my assistant put these care pathways on a piece of paper. When I was watching, I literally doing the assistant and the director and running the observation unit.
And we essentially had orders and order sets. But in 8 months, we had to teach an entire new workforce how to deliver observation care. And they had no idea how to do it. We were one of the 50% of the time institutions that didn't have an observation unit. So we literally put pen to paper and described care pathways, and we put them into Visio. And you know what was really interesting? Every Monday, my assistant would make a booklet, 10 of them, just put in every zone of the pathways, and by the next Monday they disappear. We literally could not find out where they were. Well, eventually we found out that the medicine residents had stolen them, and they took them upstairs, and they were using them. So they became a really important part of our care delivery, which I'll share more with you about that journey. We also created data and analytics around performance, and this was not only around ultimately the department division, it was attributable down to the individual provider level, ultimately the nurse level, ultimately the tech level, ultimately the housekeeper level, in metrics for performance. We said we would be data driven, and ultimately we were, and we focused on measuring what mattered for each of the individuals in our organization. So ultimately, start results. We built this process to have a increased capacity of 15% without any additional resources. The scribes those were an additional resource, but the others were all the repatriation. And actually, within our first 6 months, we saw a 30% increase in our total census. Yet, our door-to-dock time stayed less than 15 minutes and actually was closer to 10 minutes, despite that 30% plus capacity increase. Our left without missing rates were negligible, and actually our left without missing rates were quite low. Our arrival to admit decision was about 2 hours across the entire faculty practice of 75 faculty. Again, really drilling into care variability and developing care pathways. And as you can see, our discharge length of stay was under 2 hours, despite a 30% increase in total volume. And our total costs went down. And then I'm actually the most proud of this. Our MDQI nursing engagement scores were one of the highest in the country, and we maintained that for a number of years, 99.9 percentile. And this is for all of our staff, hundreds of staff. So we had the opportunity to publish our results, and we had many locations from not only across the United States, but also the world come and visit us. The Ministries of Health in Singapore, UK, Ireland, etc. came to look at our care redesign, our leadership journey, and what we ultimately implemented, and then obviously the scholarship that we created by influencing other institutions, many of which folks from their institutions had come to visit us and implemented them. Ultimately, our redesign and focus on innovation was one that became really important, not only to our department, but ultimately our health system. And I didn't mention before, but my chair and I co-founded our Health Systems Care Innovation Center. And now we lead initiatives to partner with digital health companies to grow and scale their solutions. This was in part, the pathways that I showed you, for instance, was one of our first partnerships. And we partnered with a digital health company to embed those electronically within the EHR. The company called Agile, which actually a number of other emergency departments have now partnered with that company. And I'm now implementing the development of care pathways across an entire health system. In the last year, we've just implemented 80, and we're looking at pre-op, intra-op, post-op care, for instance. I just reviewed 3 pathways on the flight here around anesthesia care for AICDs, etc. Anyway, and we also have a venture fund, so I'm happy to talk to you a little bit more about that. We're doing some other cool stuff now. We're doing virtual surveillance, which has really been escalated because of COVID, and is a prelude to a hospital-at-home process, all of which is managed by emergency physicians. Why? Because we can take care of a huge swath of different types of patients. We're comfortable with ambiguity, and we're comfortable with recognizing deterioration, and when there's a need to remediate
I'm not as good as Dr. Wiler, so I still need to be able to peek at what my next slide is. So I'm going to stay up here, and I'm not going to stand down there. And I know it's really awkward to be standing on a platform and talking to everybody. It's really good for my ego. So my wife says I don't need that. But so we're talking about, this is what happened in 2013. Now, if my math is correct, that was 9 years ago. Now, we have had turnover in our faculty over that 9-year period of time. So not everyone got to live through the change of our department, to see the change, what happened, and become invested in it. So how did we, as a department, maintain and sustain the culture change that we had? We don't have this opportunity to build a new emergency department every couple of years and do these big cycles of improvement and have that obvious burning platform. So it's just as important as once you've done it, and you've done it right, to keep it going and to keep that buy-in. So again, it is changing the DNA of your department. Now, this is what we had when we started, was Cotter's 8 steps of progression into culture change. And since then, Cotter has actually republished and developed into a cycle of culture change, because it is not a one-time event. If you do it once and you leave it alone, you will inevitably slide back into what you were before. So this is a constant cycle, constant reassessment. Just as you let it breathe once you initiate a change, it's not just let it breathe for a week, let it breathe for a month. You're going to go back and you're going to reassess it a year later and 2 years later. And as you hire in new faculty, new nurses, new techs, everyone is going to be going through this process of adapting and coming on board with that culture. Now, in industry, whenever you have a large culture change, one of the things that is often pursued is hiring for that culture change, hiring for what you are. Now, I'm a big sports fan, and I lived in some small market areas, and we often talked about recruiting players for your team, because you didn't necessarily have, you weren't the Yankees where you could pick and choose and just buy whoever you wanted. Now, this is not something that you are necessarily going to be able to do in an academic center, because unlike a community center, you need to be having researchers and educators. Not everybody is going to be coming in thinking, clinical work is my job, it is my focus, and being excellent at clinical work is all I care about, because that's not what everyone cares about. So how do you, knowing that you have people who are hired to do education, people who are hired to do research, how do they become invested in the operational mission of your emergency department? And this starts, again, from the day that they are hired. Now, I am not a spectacular researcher. I don't have a long list of papers that I've published to throw into this slide to impress you guys. I don't have that, and I don't have a great education background of all these classes and things that I've created. But despite my lack of expertise in these areas, I have participated in the interviews for our research hires, for our education hires. They all get a tour through our department. They get to come in at 2 o'clock in the afternoon and see that our waiting room is empty. They get to review this data, and there's a member of our operations team who participates in all of these interviews so that they know coming in that operations is important to you regardless of what your role is. And for nursing leadership and tech leadership, members of the clinical physician operation teams participate in those interviews, because the dyadic triadic relationships we have are that important and that critical. It is not lip service. It is an investment of time and people in having all 3 of these missions working together, and that the culture is that we support each other. So we have our research faculty, we have our research protocols and our research funding, which is integrated with our patient care. Our residency leadership and the fellowship and the med students are integrated in operations. And with reciprocation, man, that is really sensitive. I gotta put that down. We as administrators participate in the education meetings, in the review of residents, in the development of the research protocols to make sure that they work well with what we are trying to do and the care we are trying to deliver to our patients. And this is where it gets to that next step in Cotter's cycle, is engaging and enabling the whole organization. Operations is not a job of the medical director, the assistant medical director, with the chair and a few other people as needed. It is everybody's job, and everybody considers it. But because when we are successful, we are all successful. I put up these stats at the beginning just to let you know, like, hey, we are good at our research. We are good at education. I wanted to get that buy-in from the group to know that we aren't just a clinical shop. But I also put in, right on this slide, what we were back in 2012 and 2013. We're number 9 right now. We have 16K awardees. Back in 2012, we had 3. So we achieved clinical excellence, and that provided a standard, a platform for research excellence. We went from $400,000 in research to almost $16 million in that same time period. We were invested in improving our clinical operations, and because we had good clinical operations, it enabled excellence in research. And because we were excellent in research, it supported our clinical operations, that we were able to provide great care. Similar with our education. We were determined, we went and we assessed our residents, and we determined, okay, having APPs, having that physician up front who's seeing people and potentially discharging those ankle sprains that residents don't even get to see during daylight hours, they still have overnight. Is resident education negatively impacted? Is addition of APPs, caring for some of these complex patients, negatively impacting our residents? It's not. We have 69 amazing residents right now. We have fellowships galore. We've got an amazing observation service, and everyone is involved in all aspects of the patient care. And these are some of the examples, just a few examples of the committees that we have that cross-pollinate between our research, our education, and our operations. So clinical research implementation, we don't have research protocols that are developed in isolation and then brought to see how we can make it work. There is a member of the operations team involved with developing those research protocols before they get submitted to make sure that we can make them work. The education committee, case review, we have members of our research and our education team come to our quality meetings so that we can have case review decide what our residents and what our faculty need to know. We have nursing representation at many of these meetings. We do the RPMs on an ongoing basis, a couple of them a year, where we gather representation from our nurses, our techs, our faculty, day shift, night shift, APPs, to get together and decide how are we going to build this and make it better. This is not a one-time thing. This is ongoing involvement from everybody, every member of our team, and we all work together in this. And this is how we create a climate, not just for the change that we did, the big change, but ongoing and sustained change. Now, we talked about the burning platform, the idea that this is a disaster, something is going to happen, or if we don't do something, something bad is going to happen. We have to change. Well, what we have been able to develop that is into more of an intrinsic motivation on behalf of our faculty. Now, not everyone who comes to us knowing that operations is critically important to the education and research mission. But by involving the operations team in research and education, and involving education and research in operations, having them participate in our rapid process modules where we're doing this improvement, helps them understand and really be bought in to the importance of operations in their work, not just for patient care, but for research and education. And they are then intrinsically changed and developed into something that they might not necessarily have been when they started with you. It was in them all along. Like I love the butterfly picture because it was there, but it needed the right environment and the right circumstances to become an education-focused or a research-focused provider who appreciates and respects the importance of operations in their job for patient care and for research and for education. So, getting everyone together, constantly being involved in each other's aspects of care, the academic mission of your department, and constantly re-engaging and reassessing your state, making sure you're always changing. There's never content with where you're at, but improving and involving everybody in that process is how you sustain the change and avoid sliding back into old practices. So that is our presentation. This is our email for any questions or comments that you come up with after the fact. But if you have any right now, we would be glad to answer them for the next few minutes. Yes, please.
Two questions. I'll start.
Yes.
It seems like you had an amazing opportunity because you had to start from scratch. So I'm wondering, what are things that you were doing before that you weren't starting from scratch, but you were sort of trialing or trying to implement in the operations standpoint to get ready for this, or what type of things were you doing with your culture to get ready for that change?
The answer is prior to this, it was, I mean, typical strategies that goes do in operations, right? You had committee reviews, you had meetings, you know, you're sort of skating from fire to fire. So there's no question being able to leverage the opportunity to move to a new ED gave us an instant learning platform. That said, again, in my day job, I'm now working with Department of Surgery, Department of Anesthesia to create opportunities. Sadly, we have learning platforms in many places. Often they're around quality and safety issues, less sexy and motivating in my mind on cost, pressure related issues. So I think we just have to be creative to create the narrative, and it's not inappropriate escalations. But again, speaking on behalf of our patients, right? I would even use, and I did this actually recently at one of our service line cancer meetings. And I was asked the question, what keeps you up at night? And the answer was, yeah, we're one of the only comprehensive cancer centers in the Rocky Mountain region. But if 3 patients came in who all had a similar diagnosis, I'm not sure they get the same care, depending on which facility they went to. That's a problem. That should be a platform for us. So it doesn't always need to be something that's huge. You can create something that's meaningful, and we're so lucky to be in an industry that's mission driven, right? We have mission driven.
And while that was definitely a large burning platform, COVID was another burning platform opportunity for change, which on a federal government level, increased support for virtual care. At a more local level, increased support for interfacility transfers. There are all the platforms are there. The fires are, I'm pretty certain, are burning at everybody's institution, but it is finding them and really drawing attention to the fire as you're sort of leveraging your opportunity to make these changes. Yes.
So actually kind of going off that topic, one of the things that one of our mentors, or one mentor recently said is it's hard to create a crisis state when every day feels like a crisis. Like it becomes a new normal. So like we talk about our platforms during COVID, there was a peri-COVID era where we had that huge influx in patients, and we had the Omicron wave. Like every couple of months it seems like a quote crisis. And in the scope of operations, yes, you can move from one thing to the other, but at the same time, when you're pushing your faculty, when you're pushing residents, when you're pushing like people to do more, act more, think on their feet while in a shift, not operationalizing everything, I think it like produces this significant amount of burnout. Like how do you manage that, right? Like you're talking about management and culture change and creating crises, but the more crises we have, it pushes people to burnout. So like how do you balance the two?
Yeah, so in point of fact, during COVID, we ceased a lot of the work that you saw here. We did not have those rapid process modules where we got everyone together and we enacted change on a large scale because there was like everything was burning around us. You know, copy the guy with the mug saying this is fine. Like that was the life that we had. Is everything was on fire. So we made a deliberate decision to stop doing this, to respect the emotional well-being of our team and our faculty. That said, as things have started to calm down, and I say that not being all over this, visible everywhere, we have made the deliberate and very conscious and public decision to say, hey, we stopped doing this. You just started working with us in the last year and a half or 2 years. You have never seen one of these RPMs. But we used to do it all the time, and we are going to start doing it now. We've done since then, I believe we've done 2. Like, not a ton, but we are easing ourselves back into it. We are doing these again, we're doing these large-scale changes because we uncovered more problems during the last 2 years, but we focused and localized the decision-making because it was so time-sensitive, and we are now getting back to that. And it has been a bit of a challenge. Just like we stopped working out for a couple weeks, it's hard to get back into it. It has been challenge, but we have a team and a faculty group, especially those who've been here for a long time, who know that it works and are invested in making it work and becoming that kind of center.
Yeah, I totally agree. Go, no go decisions are really important. Totally agree with Todd. This is why I have a team of around 70. And we are doing the way to tackle this for us as an organization, where our managers are like, potty, club, city, like, what metric am I chasing today? Is some really deliberate annual planning. This year, here's what we want to accomplish. And then when we accept, we use the OKR methodology of objectives and key results and say, what are those exact tactics we're going to do quarter to quarter to show success? And again, I think right operations is running to those fires. And although 50-75% of your attendees, and certainly many of your core leaders, are in both your quality committee, your operations committee, your PI committee, what's nice about having the space of the PI committee is that you're constantly looking aspirational. So again, in my current day job, I like to talk about, even though it's one of those personality tests, basements and balconies, right? There's essential care, and then there's quality care. So basic blocking and tackling, safety, that's operations. But when we're aspirational thinking about what does excellence look like, and now people in our organization like to say, I didn't know it would stick, it seems it's sticking. What's perfect care, right? That's something that we're striving for. You know what's interesting? If you actually look at the operations literature and look at definitions of an HRO, right, a high reliability organization, you know, that kind of focus on outcomes, even if it's hard to do, actually is really motivating to people. So it's this balance, to your point, of not trying to skate to too many fires, but reframing and allowing PI to be a separate thing with a different longitude and potentially different resources. We have found culturally to actually, it's funny, it brings up the bottom pretty quick.
I think we can, deadlines are a little bit plastic, so if we got good questions, let's keep going.
All right, go. More respect, everyone's time.
So one of the things we're seeing post-COVID is a lot of travel nurses in our institution have travel techs. And we talked a lot about our institution, the need for culture changes in certain areas. And I kind of struggle with it. Do you think that makes it easier for culture change, or is the rapid turnover something that will make it more difficult? And how do you approach that? You're trying to bring in culture change with rapid change and stuff.
I think and not to avoid the question entirely, but it's both. Because you do need a good solid foundation of people who are bought into a culture change to sort of shepherd new hires into that culture. And if your culture is, if you have a 66% turnover, 2/3 of your nurses change, you can't, 1/3 of nurses can't shepherd the remaining 2/3. And those nurses will be bringing with them the culture that they had before. That's their normal, that's what they know. So, but when someone enters a new environment, if you set it up with operational team members participating in those interviews and everyone getting onboarded with that operational perspective, it allows people who are maybe resistant to move on, and if someone gets new, they are excited and malleable and ready to change just because it's a new hire. So in small doses, turnover is wonderful. In large doses, it can be very, very challenging. And certainly that's something that we have had to deal with as well, with the turnover of nurses. And how do we, as we onboard them, deliberately make sure that they are getting inculcated into the culture that we have developed. And it's not something that happens passively. You need to be very deliberate about what you do. And that's a team up with your nursing and physician leadership.
Yeah, it's a crisis, right? I mean, there's lots of papers published on this, and this is right the number one concern about the American Nurses Association, the AHA, fill in blank. It is absolutely a problem having people who are temporary employees who cannot build a sustained culture or process on that model. That says operational leaders, if there's an opportunity, there's always
response. We'll give you guys a little bit of time for a formal break. We're going to be back at 3:15. There's going to be ample opportunity to ask a lot more questions during our panel, and we have a great talk by Willie Baker coming up. So